Welcome back guys. Today let's study about pheochromocytoma. But before studying pheochromocytoma, let us understand the classification of neural crest tumors. The neural crest tumors are divided into two types: adrenal neural crest tumors, extraadrenal neural crest tumors. Adrenal neural crest tumors are called as pheochromocytomas. Extraadrenal neural crest tumors are called as paragangliomas. But remember, paraganglioma is a very controversial term because before we used to say that paragangliomas are those tumors which behave like pheochromocytomas and they are originating from extraadrenal site. But now recent Harrison 21st edition update says that paragangliomas are those tumors which are present in skull base and head and neck region. And the tumors which are present extraadrenally, these are just called as extraadrenal pheochromocytomas. Now, what are the association of pheochromocytoma? In order to remember the association of pheochromocytoma, let's remember it with a mnemonic, that is L, M, N. L stands for Lindau syndrome, which is von Hippel-Lindau syndrome. M stands for Menn syndrome, which is multiple endocrine neoplasia. N stands for neurofibromatosis type 1. Now, let's know about the location of these tumors. These tumors most commonly occurs in the adrenal gland. They can also occur in extraadrenal gland. If they are occurring in the extraadrenal gland, the most common area is organ of Zucker-Kendall. They can also occur in ovary and urinary bladder. Remember, if they occur in the urinary bladder and the person urinates, during the urination, the detrusor muscle contract. When the detrusor muscle contract, the tumor also contract. When the tumor contracts, there is a release of catecholamines. These catecholamines causes the episodic hypertension and tachycardia in these patients. So what is organ of Zucker-Kendall? Organ of Zucker-Kendall is that area which lies adjacent or nearby to superior mesenteric artery, inferior mesenteric artery and bifurcation of aorta. The area at this location is called as organ of Zucker-Kendall. Now let us understand the pathophysiology of these tumors. Where are these tumors coming from? These tumors are actually neural crest tumors which are coming from the sympathetic ganglia. And what do they secrete? They secrete three types of hormones: epinephrine, norepinephrine and dopamine. Now the histopathology of pheochromocytoma consists of a peculiar Zell-Whelan pattern. This Zell-Whelan pattern consists of central nest of cells called as chief cells and peripheral sustenticular cells. These chief cells are rich in synaptophysin and chromogranin, and the peripheral sustenticular cells are rich in S100. Now there is a old rule which is called as 10% rule, that is 10% of tumors are bilateral, 10% of tumors are seen in little children, 10% of tumors having active calcification, 10% of tumors are malignant and 10% of tumors are extraadrenal. This is actually an old rule which is obsolete nowadays, but some of the examiners keep asking it. But if you want to remember something out of it, just remember the malignant pheochromocytomas, now called as metastatic pheochromocytomas, and the pheochromocytomas are said to be malignant when they involve the lymph node. Now let's study about the clinical feature of pheochromocytoma. Think to yourself, what could be the most common symptom of pheochromocytoma? Is it anxiety attack? Is it weight loss? Is it abdominal pain? No. The actually most common symptom of pheochromocytoma is headache. Yeah, there will be a severe headache to the person. Yeah. Apart from headache, the person can also have other clinical features. Just make a note of it for theoretical purpose. He can have anxiety attacks, he can have pallor, polydipsia, sweating, dilated cardiomyopathy, palpitation, constipation. Yeah, most important clinical feature, that is hypertension, which we will study in detail little later. Now, there are many clinical features to remember, but you have to remember two main concepts, which is called as catecholamine crisis and pheochromocytoma triad. Now first, let's understand the pheochromocytoma triad. In order to understand the pheochromocytoma triad, assume there is a person who is having heart attack. Whenever a person is having heart attack, he has palpitation, he has sweating. Because of palpitation, there is more pumping of blood to the brain, which causes headache. So the triad consists of palpitation, sweating, headache. Now one more important feature is catecholamine crisis. Let's remember this catecholamine crisis as a side effect of hypertension. Whenever a person has hypertension for the long time, he can have IC bleed, of course. If the hypertension is for a long time, he can have heart failure. Because of heart failure, the back pressure increase and it causes pulmonary edema. So the triad is IC bleed, heart failure, pulmonary edema. Now, related to blood pressure, the patient can present in two ways. One is episodic hypertension, that is paroxysms of hypertension, and two, he can also present in orthostatic hypotension. What is orthostatic hypotension? Now, assume the person is sleeping for quite some time and you make the person to stand up and measure the blood pressure at 1 minute and 5 minutes. At 1 minute and 5 minutes, whenever we measure the blood pressure, if there is a drop in systolic blood pressure by 20 mm of Hg or diastolic blood pressure by 30 mm of Hg, or there is increase in heart rate of 30 beats per minute, then we say the person is said to having orthostatic hypotension. Now let's investigate about pheochromocytoma. There are two sets of investigations, plasma investigations, 24-hour urine assays. In plasma investigations, plasma-free metanephrines are found. This is actually more sensitive test than the 24-hour urine assay. In 24-hour urine assay, we also find the metanephrines, but it is comparatively less sensitive. We can add catecholamine assay to either of these tests in order to increase the sensitivity of the tests. Once pheochromocytoma is confirmed, in order to confirm pheochromocytoma, the value of catecholamine should be increased 3 times the base value. Once pheochromocytoma is confirmed, we are doing now abdominal CT and MRI. There is something called as DOPA-PET and PET-CT. This is actually very costly, although it is highly sensitive and specific. Because of cost basis, we don't do that. So once we do abdominal CT or MRI, we get two results. Either there is presence of pheochromocytoma or there is absence of pheochromocytoma. If pheochromocytoma is present, we will do MIBG. If pheochromocytoma is absent, we will do MIBG again. Why are we doing MIBG? Or MIBG alone can be done. Why there is need of abdominal CT or MRI? Because abdominal CT or MRI is more specific or more accurately finding lesions in abdominal area, but MIBG finds more accurately the lesions in extra abdominal area. So now what is MIBG? MIBG stands for meta-iodobenzyl guanidine. So this MIBG can use it to find the extra abdominal mass and can also use it to treat it also. Now we do MIBG in a person positive for pheochromocytoma in abdominal CT or MRI because in order to locate the extra abdominal masses of tumor. Similarly, if the abdominal CT or MRI says negative for pheochromocytoma, we are doing MIBG in order to find the extra abdominal sites because we have got the catecholamine values 3 times the base value. So there should be some tumor present which is secreting the catecholamines. Let's study about the treatment protocol. Before studying the treatment protocol, remember a point that we should never do a biopsy in pheochromocytoma patients because whenever we put the needle, the tumor releases so much of catecholamine such that the person can go into hypertensive crisis and can die. Now the final treatment option is resection of the tumor, but before resection of the tumor, we have to put the patient on the phenoxybenzamine. Now, before taking patient for surgery, we have to add phenoxybenzamine, which is a long-acting alpha blocker. What if the patient have some acute episodes of hypertension? In that situation, we will be adding the prazosin or phentolamine. Now, assume everything is completely normal and hypertension is well controlled, and we take the patient for surgery. Intraoperatively, because of the inadequate alpha blockade, the person can go into hypertensive crisis. During that situation, we have to add nitroprusside infusion. Similarly, if there is over alpha blockade, the person can go into hypotension. During that situation, person responds well to IV fluids.